Good evening and welcome to Extra-Intestinal Manifestations of Crohn's Disease and Ulcerative Colitis, a webinar presented by the Northwest Chapter of the Crohn's and Colitis Foundation of America. My name is Kathleen Newbold, and I am the Regional Education and Support Manager for the Crohn's and Colitis Foundation's Northwest Chapter. Before we get started, I'd like to share a little bit about what we do here at CCFA. Our mission is to cure Crohn's disease and ulcerative colitis and to improve the quality of life of the children and adults affected by these diseases. CCFA works to achieve this mission through funding research and education and support programs to help people living with Crohn's and colitis. CCFA is a leading supporter and funder of medical research in Crohn's disease and ulcerative colitis, funding the best IBD research anywhere in the world and implementing a peer review process that ensures that only the most promising and relevant grant applications are funded. With more than 1,000 grants awarded and a total of over $169 million invested, CCFA has played a role in every major scientific breakthrough in IBD. CCFA holds in-person education programs throughout the country. These events provide an opportunity for patients to ask providers questions and meet others going through similar experiences. Local healthcare providers speak on topics such as treatment options, nutrition, coping, and pediatric issues. Here are some of the upcoming events in the Northwest Chapter. CCFA also holds live webcasts like this one featuring expert providers and researchers in the field of IBD, then posts replays at ccfa.org/resources/webcasts. Stay tuned for details on future educational webcasts, including one on complementary and alternative medicine this July. Professional education ensures that providers can treat their patients with the best practices in IBD care. CCFA holds volunteer-driven support groups held monthly in communities around the country for people with IBD and their families. For group locations and meeting times, as well as guidelines for starting a new group, please see ccfa.org. Our Power of Two program matches those seeking support with volunteers who have gone through similar experiences with IBD, either as a patient or as a caregiver. The two speak on the phone or by email. Our free online community provides a venue where you can participate in discussion boards, read personal stories, ask a question to our panel of experts, and much more at ccfa.org. Camp Oasis is a special program for kids and teens ages 7 to 18 living with Crohn's or colitis. There are 12 camps around the U.S. The Northwest location is on the Olympic Peninsula in Washington. Camp Oasis is a safe place where they can feel normal with their peers and have the chance to try things they've never done. Volunteer counselors and 24/7 medical staff make this week possible. Applications for campers and volunteers are available now through April. These education and support programs and the critical research being conducted are funded in part by our fundraising programs. The Take Steps Walk is a community event bringing together patients, family and friends, healthcare providers with a shared goal to find a cure for Crohn's disease and ulcerative colitis. Participants raise funds and awareness in the months leading up to the event to help make an impact in the fight against inflammatory bowel diseases. On the day of the walk, participants will gather together for festivities, food, and a 2 to 3 mile walk. Join us for Take Steps and help us spread more knowledge and awareness and raise crucial funds for a cure. After attending this webinar tonight, we hope you'll feel empowered and inspired to act. Take Steps is a perfect next step to get involved. Here are some of the dates for the events in the Northwest Chapter, and there are events around the country. Team Challenge is an endurance training program that provides professional coaching and a supportive team to help you train for a 13-mile half marathon while you fundraise for cures to Crohn's and colitis. In 2014, our Northwest teams will be going to Napa, California, Kona, Hawaii, and Las Vegas for half marathons. Now I'd like to tell you a little bit about the GoToWebinar program. and make sure that you know how to use that tonight. You made it into the program, so you get the first step done. So now to ask a question, if you have a question during the program, you will type it into the question box on the control panel on the right side of your screen, and then once our presenters finish their presentation, the moderator will read the questions out loud, and the presenter will answer for everyone to hear. During the presentation, we may ask for audience feedback. On your control panel, you'll see a little hand. So go ahead and click this, and that will raise your virtual hand. So go ahead and try that now. Good. I see some hands popping up. Go ahead and click that little hand. That's on the right side of your screen. Great. I see them popping up. Great. Thank you. I'm going to put them down. Another way that we may ask for participation is through a poll. So I'm going to try a test poll now to show you. And now this is kind of a goofy one and has nothing to do with extra-intestinal manifestations of IBDs. So the poll is asking you, who is your favorite superhero? So go ahead and click the answer. Oh, Wonder Woman is in the lead. Here we go. So we'll give you a few seconds to fill that in. Also want to let you know that we will be recording this presentation, and it will be available for replay after the event. And I will send a link out to all the registrants once it's ready. Great. So I'll close, and I will share the results with you, so you can see that I've got our winner here. But it was a close race. Okay. So now I would like to introduce our moderator, Teresa Walks. Teresa is a registered nurse at the Inflammatory Bowel Disease Center at Seattle Children's Hospital. She's been treating IBD patients for 15 years now. She serves on the CCFA Northwest Board of Trustees and is the chair of our mission committee. She's also a member of the Chapter Medical Advisory Committee and a regular speaker at patient education programs in the Seattle area. Teresa has been the course co-chair for our annual professional education program for nurses since it started in 2009. Teresa is also the co-medical director and head nurse at Camp Oasis Northwest and has volunteered countless hours of her time to this program since 2006. Without further ado, I will hand it over to tonight's program moderator, Ms. Teresa Walks.
Thank you, Kathleen. Welcome, everybody. We've got participants from all over the Northwest and down the coast, so we really think you'll enjoy our program tonight. Our speaker is Dr. Ashley Larson, who's going to talk to us about extra-intestinal manifestations of inflammatory bowel disease. Dr. Larson received her medical degree from Oregon Health Sciences and then became a Washington Husky and did her internship and her residency at the University of Washington, and then continued with a 3-year GI fellowship at University of Washington. She did a month post-fellowship at the University of Chicago. And Ashley, I apologize. One of my best friends from high school is Ashley Larson. I just called you Ashley Larson after that. I apologize. I do know who she is. My classmate from West Liberty High School. So again, thank you for joining us, and Dr. Evans, we'll look forward to you educating us on the extra-intestinal manifestations of IBD. Thank you.
Sure. Thanks for the introduction, Teresa, and don't worry about the name. I was actually thinking, gosh, I hope my parents aren't listening. They're going to be very concerned I've gone and changed my last name without telling them. So thank you very much to Kathleen and to Teresa for that introduction and for involving me in this webinar, which I'm really excited to give today, and really excited to be part of the CCFA. It's such a wonderful organization. So can everyone see my screen, Kathleen and Teresa? Is my screen live?
We sure can.
Okay, good. So tonight we're going to talk about the management of extra-intestinal manifestations of inflammatory bowel disease. And the first question, of course, that pops to mind is, what are extra-intestinal manifestations? And when I told my husband, who's not in healthcare, that I was going to be talking about extra-intestinal manifestations, he said, extraterrestrial manifestations, and was a little bit alarmed. But we're not talking about that tonight, of course, which has nothing to do with inflammatory bowel disease. We're going to be talking about inflammation in other organ systems of the body that's related to bowel inflammation. And it's not entirely clear how this occurs, but the pathogenesis is thought to involve an influx of inflammatory cells, which are activated in the intestine and then are sent aberrantly or to the wrong place to other organs and cause inflammation in these other organs. These manifestations or these symptoms can occur before, during, or after exacerbations of the bowel disease, and they usually improve upon successful treatment of the IBD. So where can these extra-intestinal manifestations of IBD occur? As the picture pretty clearly shows, it can occur all over the place. The ones we're going to talk about tonight are those that occur in mucocutaneous areas, muco meaning mouth, cutaneous meaning skin, ocular or eye, musculoskeletal, muscles and joints of the body, hepatobiliary, hepato is liver, biliary the bile ducts that drain the bile from the liver, renal or the kidney system, and vasculature, our blood vessels. All of these organs can be affected by inflammation related to IBD. So who gets extra-intestinal manifestations? I'm actually going to ask for a show of hands now. How many of you have been told that you have an extra-intestinal manifestation of inflammatory bowel disease? So we'll ask you to raise your hands, your little pointer hands, your virtual hands. Well, actually, up to 40% of patients with inflammatory bowel disease can develop extra-intestinal manifestations. So this is very common. It happens to occur more commonly in patients with Crohn's disease. There's a higher incidence in patients who have colonic involvement than in those with no colonic involvement. So it seems that having your colon inflamed when you have Crohn's puts you at increased risk for extra-intestinal manifestations of IBD. And up to 25% of patients, so a quarter of patients with one extra-intestinal manifestation will have more than one. We're going to start by talking about mucocutaneous extra-intestinal manifestations. And the three topics we're going to discuss are aphthous ulcers, erythema nodosum, and pyoderma gangrenosum. So we'll talk in depth about each of these. First of all, this is probably something that almost everybody recognizes. This is an aphthous ulcer or a canker sore, commonly referred to. These are round or oval in shape. They're usually very clearly defined ulcers. They're painful. They can occur on the buccal mucosa, which is inside the cheeks, the labial mucosa, or inside the lips, on the floor of the mouth, or on the tongue. They typically last 10 to 14 days. And they usually heal without scarring. They're more common in patients with Crohn's disease. About 10% of patients with Crohn's will have frequent aphthous ulcers, and only about 3% of patients with ulcerative colitis. So aphthous ulcers actually have several different causes. In Crohn's disease, we can actually see involvement of the disease itself in the mouth causing ulceration. So if these ulcers are biopsied, they would actually show the classic pathology associated with Crohn's. Nutritional deficiencies, especially vitamin B12, can give patients aphthous ulcers in the mouth. And medications, and classically we know methotrexate can do this as a side effect. So how do we treat aphthous ulcers? The focus on treatment is really aimed at alleviating pain and expediting healing. Anyone who's had a canker sore knows that these are very painful and they can be super bothersome, and so we want to get rid of them fast and we want to make the patient feel better. So we use topical lidocaine, topical steroids, a medication that's over-the-counter called Orabase, which can diminish inflammation and improve symptoms, and Amlexinox, which is a paste that's been shown to accelerate aphthous ulcer healing. Of course, it's important to correct any nutritional deficiencies because this can be the cause of aphthous ulcers, and certainly if the methotrexate is the cause, that medication can be withdrawn or lowered in dose. Let's move on to another mucocutaneous extra-intestinal manifestation, and first we're going to talk about erythema nodosum. This is a cutaneous inflammatory disorder. So erythema nodosum, some of you may recognize this. You may have had erythema nodosum. This is a pretty classic appearance in this picture. This occurs in about 4% of patients with IBD. Seems to occur more commonly in women than in men. And the classic appearance is just as you see here on the right, a tender subcutaneous nodule that has a red or a dusky appearance. These usually occur on the shin or the pretibial region. And there's often a strong association with joint symptoms. So patients who have joint inflammation will often have erythema nodosum. And erythema nodosum tends to occur during exacerbations of IBD. And it improves when you treat the IBD. So that's good news. This is the last skin manifestation we're going to talk about, and as you can tell from the picture, it's quite a bit more severe than erythema nodosum. This is called pyoderma gangrenosum. So pyoderma gangrenosum, fortunately, is more rare than erythema nodosum. It only occurs in about 1% of patients with IBD. It usually starts out as just a papule or a pustule that progresses to an ulcer, like you see here in this picture. These usually occur on the leg or around a stoma, so someone who's had a stoma place can develop pyoderma gangrenosum around the stoma, but these can actually occur anywhere. And the classic appearance is a violaceous or purple rim and this crater-like appearance with these pits and holes in the ulcer base. And this is usually related to the activity of IBD. So sometimes can come on with a flare of the bowel symptoms, but it can also occur without an associated flare. So these are two cutaneous conditions that are treated in different ways, and we'll go through the treatment of both erythema nodosum and pyoderma gangrenosum. So for erythema nodosum, because it occurs in association with flares of bowel disease, we control the bowel inflammation, and that's the first-line therapy. But it can require systemic steroids or immunosuppressive therapy in order to get erythema nodosum under control. Pyoderma gangrenosum, because it can occur without bowel inflammation, it can respond to the treatment of IBD, but we might need to use intralesional steroid injections to treat the ulcer itself. Topical therapy might be required with cromolyn sodium, mesalamine, steroids, or tacrolimus. Systemic steroids or immunosuppressants such as cyclosporine may be required. And anti-TNF therapy, so our medications such as Remicade and Humira and Cimzia seem to be effective in treating pyoderma gangrenosum. One thing to note about pyoderma gangrenosum, this can often be confused for an infection, and so antibiotics will not treat PG. And one thing that all patients should know is that it should not be biopsied because a biopsy can actually worsen the ulcer. So two important points about pyoderma gangrenosum. We're going to move on and talk about ocular extra-intestinal manifestations of IBD. Ocular manifestations seem to occur in about 6% of patients with IBD. The three that we're going to talk about this evening are episcleritis, scleritis, and uveitis. They have different names because they affect different layers of the eye. So over on the right, you'll see a picture of episcleritis. Episcleritis affects the sclera and the conjunctiva. So I've circled in red here the layers of the eye that are affected by episcleritis, and they're the more superficial layers of the eye. Fortunately, episcleritis does not affect visual acuity. And it does occur in association with active intestinal disease. So these symptoms tend to be associated with your flares of IBD. Scleritis is very similar in presentation, affects a slightly deeper layer of the eye, and this can impair vision, and fortunately also parallels bowel inflammation. So you'll pick up a pattern here that things that parallel bowel inflammation respond to treatment of the bowel inflammation. So that'll be a pattern that'll become pretty obvious here as we go along. So this is in contrast to uveitis, which is a more serious condition and requires a more prompt evaluation. Uveitis is an inflammation of the iris. As you can see, I've circled that layer of the eye here on the right. And in the picture, you can tell that the eye is more inflamed and that pupil is quite dilated. That's because the iris is involved in the inflammation. Uveitis typically manifests with headache and deep eye pain. Patients will often have tearing or lacrimation, blurred vision, and photophobia, which means sensitivity to light. And this will often present insidiously or slowly. It doesn't seem to come on acutely, and usually involves both eyes. This needs prompt evaluation by an ophthalmologist, so this is considered an ophthalmologic emergency. And it's because if we don't treat this, it can progress to blindness. So let's discuss how we treat ocular extra-intestinal manifestations, first with episcleritis and scleritis, which are bunched together because the treatment is the same. Control the bowel inflammation. And these usually respond very well to anti-inflammatory therapy. Uveitis, on the other hand, requires a prompt ophthalmological evaluation, and an ophthalmologist may need to use local steroid drops or even systemic steroids for more severe cases. All right, moving on to a subject that may be very near and dear to our patients' hearts, because it is the most common extra-intestinal manifestation, and that is of the musculoskeletal system. So very common for patients with IBD to have joint complaints. It can occur up to 40% of our IBD patients can have joint symptoms. And we're going to talk about arthritis, which is divided into peripheral arthropathy, meaning the small joints on the periphery, and axial arthropathy, which means the spine. We're also going to talk about metabolic bone disease. And when I say metabolic bone disease, I mean osteoporosis and osteopenia. So peripheral arthralgias is what we'll talk about first. The symptoms of a peripheral arthralgia are waxing and waning, meaning coming and going, joint pain and stiffness in association with flares of intestinal disease. This occurs in about 10 to 20% of our IBD patients. Typical symptoms are swollen, red, hot joints, and it can be asymmetrical. It can be on one side and not the other, or it can be migratory, meaning it can be in one joint and then it can migrate to another joint. Fortunately, the peripheral arthralgias are non-destructive, so if you know someone who's had rheumatoid arthritis, you know that often they can have deformities of their joints, especially of their fingers. The peripheral arthralgias associated with IBD are non-destructive. They will not cause your joints to be deformed, and they're seronegative, so if we test for rheumatoid factor, it will come back negative. The knee and the ankle are the most common joints involved. Elbows, wrists, fingers, and toes may also be involved. And peripheral arthralgia seems to be more common in patients with Crohn's than in ulcerative colitis. And as we've talked about before, it has something to do with the extent of colonic disease. So the more colonic disease a patient has, the higher the risk of arthropathy. How do we treat peripheral arthralgias? Since there's no joint destruction, we really focus on treating the symptoms. COX-2 inhibitors, you may recognize the medication Celebrex. This is a COX-2 inhibitor. This can be used to treat peripheral arthralgias associated with IBD. The reason that we use COX-2 inhibitors and not nonsteroidal anti-inflammatories such as Advil, Aleve, ibuprofen, these type of medications, the NSAIDs, can cause a relapse of IBD. So we try not to use NSAIDs in patients with IBD. Sulfasalazine can be used and has the benefits of treating the joint pain and inflammation. Methotrexate, and this has been used for years and years in rheumatoid arthritis, and so we extrapolate that evidence for treatment of peripheral arthralgia associated with IBD. Infliximab or Remicade is effective for treating the peripheral arthralgia associated with IBD, and remember, it's because peripheral arthralgias tend to come on with a flare. So treatment of the flare tends to treat the arthralgia. And interestingly, a partial or a total colectomy can induce remission of the arthritis or the arthralgia in ulcerative colitis patients, but this does not seem to be the case in a colonic resection with patients who have Crohn's disease. So I want to take a poll now. We'll go back to this slide here, and I wanted to ask people, which medication have you been prescribed for your inflammatory bowel disease? So choice A will be sulfasalazine, choice B will be methotrexate, and choice C will be infliximab. I'd like to know, which medication have you been prescribed to treat your inflammatory bowel disease? And Kathleen, are we going to be able to see the results of the poll?
Oh, can you hear me? I was muted. Yes, we will wait until...
Yeah, that's okay.
We'll wait until about 80% or so have voted, so just a couple more seconds, and then I will show the results.
Great. That's pretty interesting. So 50% of people have never been on sulfasalazine, methotrexate, or Remicade, and then another 21% of, are not an IBD patients, so hopefully would never have been on those medications. Okay, good to know. All right, so we'll skip through that and get on to axial arthropathies, which I think is a really interesting extra-intestinal manifestation. So axial arthropathies, remember, are those joint complaints that involve the spine. So these occur in about 7 to 25% of patients with IBD. It's a little less common than the peripheral arthropathies. The axial symptoms do not parallel the activity of the bowel inflammation, so that's an important distinguishing point. Axial arthropathies usually manifest as insidious or slow to progress low back pain and morning stiffness that's improved by exercise. The first axial arthropathy that we're going to talk about is sacroiliitis. So this is an x-ray on the right here of a patient with sacroiliitis. And where the arrow is pointing, there should be a nice clean black line in between the pelvic bone and the spine bones. And what you see is really an obliteration of that joint space. And so this is a fusion of these two bones due to inflammation. Sacroiliitis is inflammation of the sacroiliac joint where the pelvis and the spine connect. It occurs in about 10 to 15% of patients, and males are affected more than females. Presents as dull back or hip pain that's worse in the mornings. This does not parallel the activity of the bowel disease. And most patients with sacroiliitis are HLA-B27 negative. This is a genetic test that we use to sometimes help us determine whether or not a patient has an axial arthropathy associated with their IBD. The second type of axial arthropathy we're going to talk about is one called ankylosing spondylitis. This is a very interesting condition. On the right-hand side, you see two x-rays of a patient with ankylosing spondylitis. And whereas in sacroiliitis, you saw fusion of the sacrum and the iliac bones, here you actually see fusion of the vertebrae. This occurs in about 1 to 2% of patients with IBD. Most of these patients are actually HLA-B27 positive. The symptoms can occur long before or even after the onset of the intestinal symptoms, and they're independent of the activity of the colitis. This is commonly referred to as bamboo spine, and you can appreciate why. These patients look like they have a rod of bamboo replacing where each individual vertebrae should be. All right, so let's talk about the treatment. How do we treat the axial arthropathies? Remember, these typically occur without associated bowel inflammation, so we have to be a little bit more creative. For sacroiliitis, we can use anti-inflammatories and a focus on treatment that's similar to the treatment of the peripheral arthropathies. For ankylosing spondylitis, we've had a lot of clinical success with the anti-TNF medications, Remicade, Humira, Cimzia. And physical therapy is very important for these patients to prevent scoliosis and degenerative changes. We're going to move on and talk about metabolic bone disease, osteopenia and osteoporosis. This is a really important topic, and I think it's under-recognized in our IBD patient population. On the bottom right-hand corner here, you see a picture of a normal bone matrix contrasted to a picture of an osteoporotic bone. And it's pretty obvious what the difference is. The osteoporotic bone has a moth-eaten appearance. There's not as much bone matrix as there should be. So osteopenia and osteoporosis are a decrease in the bone mineral density. This leaves our patients at increased susceptibility to bone fractures, and the ones that we worry about the most are vertebral crush fractures. In ulcerative colitis, glucocorticoid use or steroid use is the main risk factor, and hopefully all of your physicians are telling you one of the risk factors of being on long-term prednisone is development of osteopenia and osteoporosis. This does seem to occur more commonly in Crohn's disease. Up to 60% of patients will have osteopenia and osteoporosis, and there's a few good reasons why. We're going to talk about that. First of all, in Crohn's disease, low bone mineral density occurs even without steroid use. So patients who've never even seen steroids can have low bone mineral density. That's because Crohn's disease patients have involvement of the small bowel, which is very essential for absorbing calcium and vitamin D. Also, these pro-inflammatory cytokines have an effect on the osteoclasts in the bone, which are responsible for remodeling the bone. And low body mass index, which is more common in patients with Crohn's disease, puts patients at increased risk for osteopenia and osteoporosis. Actually, being overweight or obese is one of the only things that's good about having a high BMI. Obesity actually is protective against osteoporosis. So low BMI puts you at risk for bone breaks. How do we treat metabolic bone disease? All of our patients should be on calcium and vitamin D supplementation. I make sure that all of my IBD patients are on daily calcium and vitamin D. This is very important, especially because the majority of us live in North America, and the majority of us listening tonight actually live in the Pacific Northwest, so we get limited sunlight exposure, which is very important for vitamin D metabolism. DEXA scans, which are a measurement of bone density. These are important to screen for osteopenia and osteoporosis. If we don't screen for it, we won't be able to identify the patients who are at risk for it and treat them. We should be checking serum vitamin D levels, again, to identify patients who are at increased risk for low vitamin D, which can be corrected with replacement therapy. And in patients who have worsening osteopenia or osteoporosis on their DEXA scan, these are the patients who might need the addition of bisphosphonates to their medical therapy, which are bone strengthening agents. Another really fascinating topic, we're going to talk about hepatobiliary extra-intestinal manifestations. I can imagine that there might be a lot of questions that come up about hepatobiliary extra-intestinal manifestations. We're going to talk about primary sclerosing cholangitis, drug-induced hepatotoxicity, and gallstones. So we'll start with primary sclerosing cholangitis. This is a very interesting condition. On the right, you'll see a cartoon diagram of the biliary tree. So those are the green tubes that drain bile out of the liver. You don't see the liver in this picture, just the tubes. Those tubes drain bile out of the liver, and then the bile is stored in the gallbladder. And when you eat a meal, the gallbladder squeezes the bile into the bigger tube, which empties into the small intestine, into the duodenum. In primary sclerosing cholangitis, there's chronic inflammation of the biliary tree, and this results in fibrosis and eventual cirrhosis or scarring, end-stage scarring of the liver. On an MRI, which is what you see on the bottom right-hand corner, the black and white picture over there, you have a very characteristic appearance to the MRI. You get these strictures of the bile duct and beads, so it's beading and stricturing, and you'll see areas that are narrowed and areas that are dilated, and that's the classic appearance of PSC on an MRI. This occurs in about 4% of patients with Crohn's and 8% of patients with ulcerative colitis. And patients with IBD and PSC are at an increased risk for both cholangiocarcinoma, which is a tumor of the bile ducts, and colon cancer, which we're all very familiar with. How do we treat PSC? This is an ever-evolving topic. It used to be thought that ursodiol was of clinical benefit for treating PSC. So ursodiol is a medication that when it was given to patients, these patients had improvement in their liver tests. So their AST and their ALT would improve. But when we would do biopsies, we wouldn't see a significant change in the pathology of their fibrosis and cirrhosis, and we didn't see improvement in the clinical disease progression. So it seemed that these people, even if they were on ursodiol, would still progress at similar rates to fibrosis and cirrhosis. And then recently, a trial of high-dose ursodiol using very high doses of 28 to 30 milligrams per kilogram per day. This was actually done in part in Seattle. This showed a harmful effect. So these patients actually progressed to fibrosis more rapidly than patients who were not on ursodiol. And so for that reason, the liver disease societies are not recommending that ursodiol be used for treatment of primary sclerosing cholangitis. We just don't know what the safe level is for treatment, and since high dose is harmful, any dose at this point is considered to be potentially harmful. Unfortunately, no benefit has been shown with corticosteroids to treat PSC or any other immune suppressants that we use to treat our IBD. And so treatment of primary sclerosing cholangitis is really just focused on symptomatic management. So patients who have stricturing of their bile ducts can have elevations of their bilirubin, leading to jaundice or yellowing of the skin and eyes. This can lead to itching, and blockage of the bile duct can lead to infections. An ERCP, which is an endoscopic procedure that can access the inside of the bile ducts, this can be used to treat a dominant stricture. So if a patient has one stricture that seems to be causing the majority of the problems, this can be relieved by an ERCP. It's incredibly important for patients with IBD and PSC to have frequent screening for colon cancer and for cholangiocarcinoma, that tumor of the bile ducts. And if the disease progresses to cirrhosis, liver transplant may be necessary. A little bit more straightforward topic is drug-induced hepatotoxicity. And unfortunately, most of the drugs that we use in the medical management of IBD have actually been associated with liver toxicity. But the good news is that the incidence of serious complications is quite low. So sulfasalazine can cause a hypersensitivity reaction, almost like an allergic reaction in the liver. Azathioprine can cause increased LFTs, or the AST and the ALT. Methotrexate can cause fibrosis and increased LFTs. And infliximab has actually been shown in rare cases to be associated with liver fibrosis. So what do we do to treat this drug-induced hepatotoxicity? Well, that's pretty easy. We just remove the offending drug, and it seems that the drug-induced hepatotoxicity goes away. And lastly, we're going to talk about gallstones. We're all pretty familiar with gallstones because we live in America, and gallstones are incredibly common. But it's more common in our IBD population. This can be seen in up to 1/3 of the patients who have ileitis or an ileal resection. So as you probably already guessed, it seems to be only an increased incidence in our patients with Crohn's disease, not ulcerative colitis, because it's a disease that's associated with ileal inflammation. Gallstones are caused in the IBD population by the malabsorption of bile acids. So usually the terminal ileum is involved in recycling bile acids back to the liver. It's a very efficient system. The bile goes into the small intestine and helps us break down our fats and our foods. And then in the ileum, there are transporters that actually absorb the bile acids and send them back to the liver. But if you don't have a terminal ileum, or if you have an inflamed or diseased terminal ileum, you can't reabsorb those bile salts. And so the bile in the gallbladder becomes super concentrated. And just like those crystal kits that we used to have as kids, when you have a super concentrated solution, it tends to form crystals, and then those crystals become stones. So over on the right-hand side, you see a blown-up picture of a gallbladder, cartoon picture of a gallbladder with some some gallstones in there. And then there's a picture of a gallbladder that's obviously been removed from a patient, full of stones, and it just looks infected. It's red, it's angry looking. That's a gallbladder that needed to come out. So the treatment for gallstones is pretty straightforward. We need to try to minimize our ileal resection, since this is the part of the bowel that's involved in recycling those bile acids. We need to treat active ileal inflammation, so again, treat the IBD. And if the gallbladder becomes infected or the stones are causing a lot of symptoms in patients, then the gallbladder should come out. It's a surgical procedure. Even the kidney can be involved in extra-intestinal manifestations of IBD, so that's what we're going to talk about next. Nephrolithiasis, which is a long fancy word for kidney stones, is the extra-intestinal manifestation that affects the renal system. This occurs in about 2 to 6% of patients with IBD. They can get kidney stones. This is more frequent in Crohn's disease than ulcerative colitis. The typical stone seen in Crohn's disease is an oxalate stone. We're going to talk a bit more about that in a minute. And this is caused by fat malabsorption. And uric acid stones can be seen in both types of patients with IBD. And this is typically due to volume depletion or dehydration and the fact that patients with bowel inflammation are in a hypermetabolic state. Inflammation, increased protein breakdown, increased uric acid and stone formation. This is a pretty rudimentary and simplified diagram of what happens in Crohn's disease that causes oxalate stones to form. So that picture of the bowel there, smushed in between the horseshoe shape of the colon, is the small intestine. And what happens in Crohn's disease is if the small intestine is inflamed or it's had a lot of resection, so a short small intestine, it does not absorb free fatty acids very well. Those free fatty acids, instead of being absorbed in the small intestine, they spill into the colon. And in the colon, calcium binds the free fatty acids. Well, that's a problem because calcium usually binds oxalate. And if calcium is bound to free fatty acids, then it does not bind the oxalate. And the oxalate then becomes an oxalate salt, that is a sodium salt that is absorbed back into the systemic circulation and ends up in the kidney, causing high levels of oxalate and calcium oxalate stone formation. So that's how that all happens, and it really just has to do with fat malabsorption. That's what starts the whole thing. So how do we prevent and treat kidney stones? Again, controlling the bowel inflammation to try to limit the fat malabsorption, making sure that we all have adequate hydration, trying not to get dehydrated. And if a kidney stone forms, it might be necessary to break up the stones with sound waves or lithotripsy if the stones are symptomatic or causing problems. All right, the last topic that we're going to discuss tonight, vascular extra-intestinal manifestations. I'm sure you're thinking, what is not involved with my IBD? In fact, even your blood vessels can be involved. And what we worry about are blood clots. So this can occur in the form of thrombophlebitis, which is inflammation of the blood vessels themselves, deep venous thrombosis, commonly referred to as a DVT, or pulmonary embolism, or a PE. That's what we're going to talk about. The symptoms of thrombophlebitis can be pain and swelling of the superficial blood vessels. Symptoms of deep venous thrombosis can be pain and swelling of an extremity. This usually happens in a leg. And so you'll hear people talk about Dick Cheney, and he got a DVT when he was flying. It happens in times of stasis when we're not moving our legs around, and we can get clots in the deep veins of our legs. It can occur in the arms as well, but usually it's a leg. Pulmonary embolism. The symptoms of this are shortness of breath, can be chest pain, and palpitations. So vascular extra-intestinal manifestations are caused by a prothrombotic or a high clotting tendency that's noted in both major forms of IBD, both Crohn's and colitis. Hypercoagulable means high clotting state, may arise from thrombocytosis, so that means elevated platelets. Platelets are important in clotting. If you have too many of them, your blood may clot too quickly. Increased level of clotting factors seen in inflammation, and low levels of those thrombotic factors that actually counteract the clotting factors, so anti-thrombotic factors. These can be low when the bowel is actively inflamed. And how do we treat this? Well, it might be a little bit counterintuitive, but we, of course, have to treat the bowel inflammation. And if patients have a clot, a DVT or a PE especially, these should be treated with anticoagulants. So again, it might be a little bit counterintuitive to use warfarin and low molecular weight heparin in a patient who's having bloody diarrhea. But DVTs and PEs can be life-threatening, and so we need to be serious when we talk about treating these complications. We're going to wrap it up here and talk about a few of the conclusions that I want you to take home from this presentation. So the first thing that I think is very important to recognize when we talk about extra-intestinal manifestations is that they really fall into two categories. There are those extra-intestinal manifestations that parallel the IBD, so they come on with a flare and they respond to treatment of a flare. And then there are those extra-intestinal manifestations that do not parallel IBD. So for the manifestations that do parallel the IBD, the good news is you treat the IBD and the extra-intestinal manifestation improves. These are the aphthous ulcers that we talked about, peripheral arthritis, erythema nodosum, and the scleritis and episcleritis involving the eye. Another important take-home point is that if there is an extra-intestinal manifestation, we might choose a different med that will treat both the IBD and the manifestation or the symptom. So for example, in arthritis or joint disease, sulfasalazine could be chosen by the doctor over a non-sulfasalazine 5-ASA agent, such as mesalamine. And similarly, methotrexate can be used to treat joint complaints over 6-mercaptopurine or azathioprine. And another piece of good news about extra-intestinal manifestations that parallel IBD is that these conditions are very corticosteroid and anti-TNF responsive. So those are the ones that parallel IBD. Now let's talk about the extra-intestinal manifestations that do not parallel IBD. These are unfortunately more difficult to treat. So we're talking about the axial arthritis, pyoderma gangrenosum, uveitis, primary sclerosing cholangitis. The good news is that they're often corticosteroid responsive, and they respond very well to anti-TNF therapy. Now the big exception is, of course, primary sclerosing cholangitis. If the condition is refractory to anti-TNF, there's a few other tricks we have up our sleeve. We can use tacrolimus, cyclosporin, dapsone, and plaquenil are some examples for how to treat extra-intestinal manifestations that don't respond to steroids or anti-TNFs. So I want to take one more poll. We took a brief poll at the beginning and asked about how many people had been told that they had an extra-intestinal manifestation. So now I want to know, after listening to this webinar, how many people have been told that they have an extra-intestinal manifestation related to their IBD, and I want to know the number. We discussed that some patients have more than one complication. So your choices are, how many extra-intestinal manifestations have you or your loved one been diagnosed with? Choice A is 0, choice B is 1, choice C is more than one. And we'll wait for a minute to let everybody respond. I think that's really interesting. So just like we discussed at the beginning, at least a quarter of patients who have one extra-intestinal manifestation will have more than one. So this seems to be true in our patient population here, people who are listening or have a loved one who's affected. So almost half of people have 2 or more extra-intestinal manifestations. Really interesting. Thanks for responding to the poll. All right, so there's a few more concluding notes and then we'll wrap it up. I want you to take home the fact that most extra-intestinal manifestations associated with IBD can be controlled with treatment of the bowel inflammation. But some extra-intestinal manifestations require targeted therapy and lifelong monitoring. Recognizing and treating these conditions can involve multiple different doctors working together, multiple doctors in different specialties. And as we talked about, dermatology, nephrology or kidney doctors, ophthalmology, eye doctors, rheumatology, the joint doctors, pulmonologists, lung doctors, and hematologists who are blood clotting doctors, they might all be necessary to collaborate and treat patients who have extra-intestinal manifestations. And I want you as patients and patients' loved ones and healthcare providers to understand that educated patients can really help to expedite the diagnosis and the successful treatment of extra-intestinal manifestations. So I think it's great that we had a bunch of patients listening and patients' loved ones and healthcare providers because recognition is really the first step, obviously, in treating these conditions, so very important. That's the end of my presentation, and again, I wanted to thank everybody for listening and for participating. It's been so much fun getting to work with the CCFA on this, and I'm really privileged to be a part of this group, so thanks very much.
Thank you very much, Dr. Evans. I want to remind people that if you have questions, and I've got some here listed already, but if you have questions that you'd like Dr. Evans to address, if you could just type them in the space that says type message here, and we'll try to have her address as many questions as we have time for. Dr. Evans, one of our listeners wanted to know, is there a correlation between inflammatory bowel disease and fibromyalgia?
There's no known correlation between fibromyalgia and inflammatory bowel disease. Fibromyalgia is a really common condition, we all know. It does not seem to involve any destructive inflammation of the joints. Patients can be very symptomatic. We classically think of fibromyalgia as sort of the irritable bowel syndrome of the joints. So it's non-destructive and does not seem to be associated with IBD.
Thank you. So can you talk, when you were talking about the gallbladder and all the complicated things that the biliary system has to do, does taking someone's gallbladder out affect their absorption of the bile salts? So if someone with IBD has poor absorption of bile salts or has no terminal ileum, what happens to the bile salts if they can't collect in their gallbladder because they don't have one?
That's a great question. So the gallbladder we've discovered is one of those organs like the appendix that we can live very well without. We don't need it. When you take the gallbladder out, the body really adapts very well. Instead of storing bile in the gallbladder, the bile ends up being stored in the bile duct itself. And so it does not seem to affect absorption of any of our nutrients or dietary fats. By taking your gallbladder out, your body will adapt just fine.
Thank you. So another question related to the gallbladder, everybody knows about their gallbladder, is that you talked about that there's an increased risk of cancer of the gallbladder. We know how you screen for colon cancer with a colonoscopy. How do you screen for gallbladder cancer?
Well, the increased risk of cancer in the liver is actually with cholangiocarcinoma, which is not gallbladder cancer. It's cancer of the bile ducts, and that's seen in primary sclerosing cholangitis. So a little bit of a nuance, but cholangiocarcinoma is a bile duct cancer, not a gallbladder cancer. So bile duct cancer can be screened for with an ultrasound, or a more sensitive test is using an MRI. And patients with primary sclerosing cholangitis should have serial MRIs. They're typically recommended annually in patients with PSC and IBD.
Thank you. One of our listeners is asking about collagenous colitis, and do they have the same risk of extra-intestinal manifestations as people with inflammatory bowel disease do?
That's a really interesting question. I can't say I know the answer exactly, but I'm going to take a stab at it, and then I'll look it up and make sure that this is correct after our webinar. Collagenous colitis is within the spectrum, we think, of inflammatory bowel disease, although collagenous colitis, which is often referred to as microscopic colitis, does not show the classic inflammatory changes that we associate with IBD. So when you do a colonoscopy on a patient with colitis or Crohn's disease, you can see with your eyes redness and swelling and ulcers and bleeding. It's very apparent. Collagenous colitis looks completely normal until you take a biopsy and you look at it under the microscope. So it doesn't have that inflammation that we typically see in IBD. And as far as I know, it is not associated with the extra-intestinal manifestations that we classically associate with ulcerative colitis and Crohn's disease. Again, I'll have to look that up to make sure and do a little bit more investigation, but I'm pretty sure that that is the party line.
Thank you, and we'll make sure that that additional information gets to our participant.
Sure.
So is there an age where you can no longer improve your bone density? Is there, do we lose an opportunity for getting those bones stronger?
We build up our bone density early, actually, in our teens and early 20s. And so that's really the peak time for building our bones. And as many of you know, that is the time when inflammatory bowel disease is classically diagnosed. And so it's an unfortunate coincidence that when we're supposed to be building up our bones, that's when most people are diagnosed with their IBD. But with supplementation and use of the bisphosphonate medications, we can improve bone density, especially if we're aggressive in treating it.
Thank you. So how often should we have DEXA scans? When do we start those? I mean, do we start those in our children? And at what interval should you repeat those?
Great question. So I perform a DEXA scan on all of my patients who've been diagnosed with inflammatory bowel disease. I'm not sure if there is a recommendation for the age to start, but certainly any patient who's been exposed to steroids or who has malabsorptive symptoms, which can cause a decrease in absorption of calcium and vitamin D, should be screened for osteopenia and osteoporosis. And in terms of how often to repeat them, it depends on what the DEXA scan shows. So a patient who has significant osteopenia and osteoporosis should have a short interval DEXA scan performed in 1 to 2 years.
Thank you. If working in with the pediatric population, we take that bone growth challenge very seriously.
Right.
And we scan all children within the first 6 months to a year, depending upon how sick they are. We want to give them an opportunity to get the inflammation under control. And then, like you said, if they're normal, then we may wait several years before we repeat it if they've been in remission. But otherwise, we do repeat them more frequently.
That's great. That's good to know. I'm glad you guys are doing that because you're right. It's so important, and these kids are at really high risk.
We have another listener from closer over to where you live that wants to know about, if you could talk a little bit more about the difference between what it means to be HLA-27 positive versus HLA negative. You addressed it with a couple of conditions, but overall, why do we want to know if we're negative or positive?
Sure. So HLA-B27 is a genetic marker that's been associated with both IBD and axial arthropathies. And so if it can be helpful if you're having joint complaints and we're not sure if the joint complaints are related to the IBD or if they're just run-of-the-mill back pain that a lot of us have from time to time. An HLA test can be helpful to determine if a patient is at risk for developing well, the one that is associated with HLA-B27 is ankylosing spondylitis. And so our rheumatology colleagues check these in a lot of patients who have back and hip pain to help us arrive at the correct diagnosis.
And Dr. Evans, do we consider, because there's a lot of patients that have rheumatoid arthritis and have inflammatory bowel disease, do you consider those two separate conditions, or is it considered an extra-intestinal manifestation if they actually are positive for rheumatoid arthritis?
Sure. We consider them two separate conditions because rheumatoid arthritis is a separate beast. It's not an extra-intestinal manifestation, but it is related in a way to our IBD in that we consider IBD in part to be an autoimmune condition, which is similar in rheumatoid arthritis. And as many of you know, we do use a lot of the same medications to treat IBD that are used in the rheumatoid arthritis population. So they're similar disease processes, but they are separate.
Thank you. We have to thank the folks with rheumatoid arthritis because a lot of their work in developing their drugs ended up helping our patients with IBD.
Yes, right. That's exactly right.
Are there other conditions that can cause erythema nodosum, or if we see that and there's not been a lot of GI symptoms, could it be something else, or is that always a precursor to or a simultaneous condition with inflammatory bowel disease?
Erythema nodosum can be seen in a variety of different cases. In fact, the E. nodosum that's associated with IBD is probably the minority of when we see E. nodosum. And the most common cause of erythema nodosum is actually strep throat in kids. They'll often develop this rash on their legs that's associated with the antigen to the Streptococcus virus.
Thank you. So is there a typical time period in a person's life with inflammatory bowel disease that they're more likely to see extra-intestinal manifestations? Is it the first 5 years that you're most likely to see these conditions, or is it when you've had it for a long time?
They can occur at any point during the lifetime of a patient with inflammatory bowel disease. And as we learned this evening, the majority of them tend to occur with flares of the IBD, but it doesn't seem to be necessarily at the beginning of the diagnosis or any particular time point. It can really be sporadic and throughout the course of the IBD.
Thank you. So back to the hepatobiliary system.
Sure.
When you talked about that there's really not a lot of treatment options for patients with PSC, do all patients with PSC eventually end up with a liver transplant?
The nature of the disease is that it is progressive. And since we don't have a treatment for it that is effective and safe, the natural history of PSC is that it will slowly progress to fibrosis and eventually cirrhosis. Now, people live a long time with fibrosis and cirrhosis and don't need liver transplants. And the severity of the liver disease is scored by the MELD score, which is the scoring system used to allocate liver transplants in the United States. And so it takes into factor a variety of lab tests that help us determine how severe a patient's liver disease is. The typical age of diagnosis of IBD is in the teens and 20s, and that's usually around the time that the primary sclerosing cholangitis is detected. So routine labs are checked, and it's noted that the LFTs are abnormal. Medications aren't suspected, and the diagnosis of PSC is made usually by an MRI of the liver. But even when patients are diagnosed early in their teens or 20s, it typically takes years, sometimes decades, to progress to severe liver disease that would require a liver transplant.
Thank you. That's reassuring. So I have a question that I think that our audience would find helpful. As a gastroenterologist, your patients are becoming more and more proactive, seeking out information and education, attending these webinars and attending local patient education programs, reading things on the internet. So how would you advise them to be most successful and communicate the best to their providers when they want to know, like one of our listeners, when should I start getting a DEXA scan? Or, you know, when am I supposed to have my next colonoscopy? Or I heard that, you know, Ursadile is not a great treatment for PSC any longer. Can you give people a kind of a pep talk or ways that that they can feel most comfortable in addressing these with their gastroenterologist?
Sure. You know, I think that in medicine today, physicians welcome patient feedback and questions and participation in their own care. I certainly feel like my patients are just as important to the conversation as my thoughts and opinions are. And so I really want to know what patients' concerns are. And I love when a patient comes to clinic and says, I've been reading, hopefully not on Google, hopefully on the CCFA website, but I've been reading about this therapy, or I've been reading about this complication, and what do you think? And it really is important for patients to be educated and savvy about their own conditions and be their own advocates, because you will always be your best advocate. It's a really powerful position to be in. So I think it's great that people are listening to the webinar and trying to educate themselves, because you can have a huge impact on your own medical care.
I agree, and I think it takes a team, the gastroenterologist and the dietitians and the hematologist and dermatologist and the nurses and and the social workers, all of us, to make sure that our patients with IBD get the very best care available to them. So I think that that's all of the questions that I have that our audience has posed to you tonight. I want to thank all of our listeners for coming and educating themselves about this condition. I want to thank Dr. Evans for spending the time and teaching us things that we may not have known and giving us updates on current treatments. And I want to thank Kathleen Newbold and the Northwest chapter of CCFA for hosting this event and providing patient services to all of our patients in the Pacific Northwest. So thank you very much. This will be available. It's being recorded and will be available for review on our CCFA website. Thank you very much for coming, and enjoy the rest of your evening.
Thank you.